Okay, so we're gonna go over kidneys. Um, so there's just like a lot of some of these lectures, there's a whole bunch of patho in the beginning. So I summarized as much as I could for it. And then the real focus is kind of going over acute AKI, CKD, dialysis. Uh, but knowing the patho is still good to know. But we can summarize a lot of it. So that's what I did. So this part will be kind of just talking about it. And then if you have questions, we can talk about it. So just like a general guideline summary of the kidneys are uh, they are a gluten for blood. They need that perfusion. So the kidneys actually receive more blood than the brain does, which is interesting. Do you need to know this? Not really. Just kind of get the idea how tied kidneys are to perfusion. So for example, some of the things that can lead to chronic kidney disease and general unhealthiness of the kidneys include things that deal with perfusion. And some of the things that we we talk about all the time as this is it's kind of like that Harry Potter meme. It's like it's always you three. It's always hypertension, diabetes, hyperlipidemia. It's always them. All these things affect perfusion. So your hypertension, your diabetes. So if you have something that impacts your perfusion, that means your kidneys are getting less blood. That means your kidneys are not happy, and you're gonna make the kidney sad, and it's gonna fight back. So these are your main causes of long-term kidney damage, alongside other things such as too much nephrotoxic medication for long periods of time, consistent usage of those kind of medications. But just kind of keep in mind perfusion kidneys, they go together really hard. And anything that impacts your perfusion is going to impact the kidneys. So you always got to look out for that. So then something that ties in your week 3 to this one is the connection between your liver and your kidneys. So we talked about the hepatorenal syndrome, thought to be because of lack of perfusion to the kidneys, kind of exacerbated by liver impairment and portal hypertension and stuff. And I think something that ties them together is that the RAS system involves the liver and the kidney. So if you guys recall from like first semester, or if you never went over this, essentially um, your kidneys will signal out for the release of angiotensin 1. Angiotensin 1 will go to, I believe, the lungs to become angiotensin 2, and at some point your liver will act upon it, and it ends up as angiotensin 2, go to the adrenal glands, and that releases aldosterone. So case in point, your liver and your kidneys, they go together, and you can kind of already tie them in your brain because those are your two organs that deal with things such as drug metabolism. So if something's wrong with the liver and something is wrong with the kidneys. Yeah, yeah. So yeah, Caitlin's bringing up so your Synopro and stuff. Those are used for blood pressure, and but they can also cause things like cough. And one of the ways Prills works is directly causing a inhibition of the RAS system. So lungs, kidneys, liver, and in the RAS system, all involved. But in particular, liver and kidneys, if one of them has an issue, the other one might have an issue as well. So they kind of go together. And like I was saying, you can kind of marry them anyways because they're both organs that get impacted easily by age. So as we get older, liver impairment, kidney impairment more likely, and those are the two systems that act upon like drug metabolism. So whenever these are impaired, you worry more about if this dose is right for the patient or not. So that can be a way you can marry the liver and the kidney, and then perfusion as well is also important with that. So here's just a quick review of your kidney function. So you have your RAS releases aldosterone, and in particular, this is going to very specifically retain sodium and release potassium. And because you are retaining sodium, water loves to go with salt, so water is retained indirectly. Okay. And when your kidneys are not working properly, then this whole system is not really working particularly well. You're not able to make urine is probably one of the biggest reasons why you would develop hypertension. Because your kidneys do that. They make urine, they get rid of waste. If your kidneys aren't working, you're not getting rid of all of that, and you're gonna be retaining too much liquid. So that's one of the major things that causes issues with hypertension and fluid retention with your kidneys are abnormal, not working properly. So somebody with should probably be like right here. Boop, boop. Somebody with chronic kidney disease likely to be on many antihypertensive meds. Yeah, we'll go talk more about that when we get to the kidney failure part. But think about things such as your kidneys are abnormal, so you'll see things such as BUN go up, creatinine will go up, your GFR will go down, your urine output's going to go down. Additionally, your kidneys are also something that is going to respond to ADH, so that's your antidiuretic hormone. And this is something that's released by your pituitary gland that tell your kidneys to reabsorb more water in the renal tubules. And the main things with this, just to kind of get the general idea of how the kidneys function for electrolytes and function in terms of water retention. So a few different mechanisms that allow the kidneys to manage electrolytes and fluids. So if this is abnormal, then naturally your body's going to struggle with water retention, is going to struggle with electrolyte management as well. Okay. So another, again, we talked about how the kidneys will filter waste and medications, drugs, into the urine. So if your kidneys are not working, then things can build up in the body. So think about things like metformin. So the reason we don't give metformin in the hospital is because if the patient needs a contrast, then a combination of that metformin plus the contrast can leave that metformin staying around in the body longer because contrast are often um, what's the word? Kidney. They're heavy on the kidneys, so it will cause the kidneys to be not working as well, and so the metformin stays around in the body when it shouldn't, and that causes certain issues like lactic acidosis, can cause hypoglycemia. So in general, if your kidneys are not doing too good, you're not making urine, you're not getting rid of the waste, and you're also struggling to get rid of toxins and get rid of drugs. So harder time metabolizing meds and getting rid of it. So toxicity risk increases. Okay. So again, here, drug toxicity, electrolyte imbalances, and the buildup of urea, nitrogen, and creatinine, and H plus. H plus referring to the acid. So your kidneys are in charge of acid-base balance, electrolyte balance, fluid balance, drug metabolism alongside your liver, and as well as getting rid of some waste products like urea and creatinine. So your BUN, that's your blood urea nitrogen. Your kidneys are supposed to get rid of that. If they're not able to make urine, then you're not getting rid of that, and that's when your BUN goes up. Your creatinine, this is a waste product. So if your kidneys are struggling to get rid of it, it builds up in the blood. So that's where those labs come into play and why those are indicative of kidney function. The creatinine more so than the urea nitrogen, because elevated BUN could just be a sign of dehydration. Because if you're dehydrated, you're not making urine because of lack of fluid. And so this will build up because you're not getting rid of it. But your body is very good. Your kidneys are very good about getting rid of creatinine. They hate creatinine. They say you have zero purpose and they want to kick it out immediately. So your kidneys will do their absolute best to get rid of creatinine. So even in terms of dehydration, where you don't have as much fluid to go around to make urine, your kidneys are still getting rid of this one a lot better than they're getting rid of the urea nitrogen. So that's why in dehydration you can see BUN go up, but creatinine stay normal. Because your body will do everything in their power to get rid of creatinine. Any questions so far? So to review, kidneys, perfusion, they go together. Kidney damage, a lot of goes with a lot of things that cause kidney stuff, cause perfusion issues, hypertension, diabetes, hyperlipidemia, alcohol. Liver and kidneys, they go together. They're both in charge of dealing with drug metabolism, so you can think of them together as that way. Your kidneys regulate circulating volume, so it has the RAS system, ADH, and in general, they will use urine to get rid of waste, medications, electrolytes, fluids, as well as this specific waste products, which are your labs that we discussed. So if you have any questions, just type it in the chat and I'll get to it eventually. Otherwise, we'll move on. So another thing that your kidneys do is they will, oh, okay, Kaylin got me in the chat, perfect. Your kidneys activate vitamin D. So made my smoothie song back. Nice. So your kidneys will activate vitamin D. Do you need to know the specific pathway? No. Just think about kidneys, vitamin D, and when we think about vitamin D allows for better absorption of calcium. So just from knowing this information, you can get the idea that if kidneys are not working properly, then we're going to have less calcium in the blood, which is something that we do in fact find in our labs. And then here, I kind of have a list of some of the electrolytes that are impaired when kidneys are impaired or are off when the kidneys are off. So the main one to always think about when it comes to kidney impairment is your potassium, because your kidneys are not able to waste them properly. So high potassium is one of the biggest things with renal insufficiency. Then there's also your phosphate and your magnesium. All three of these are going to be high. And something to think about for all of them is that all three of these can, when they're high, can lead to cardiac dysrhythmias. So that's like a way to cluster them together is these three, they are involved with making your heart um, beat irregularly or have the dysrhythmias, the different types of dysrhythmias. And then here I have like a little bit of extra info. Calcium and phosphate. They have a sort of inverse relationship. So when you have a lot of phosphate, the phosphate likes to bind to calcium, and um, and vice versa as well. Um, so this ends up leading, because you have such a high potassium level alongside the vitamin D thing we talked about before, your calcium ends up being low. And that's a reason why as well that some of your phosphate binders are calcium. So you can have someone with kidney problems on like uh the um calcium binders like Foslo, yeah. So that and like maybe some calcium supplementation. So calcium carbonate and yeah. So supplementation as well as the phosphate binders. Okay. And then out of all of these, another important lab to think about is your sodium. So in this particular case, you have low sodium, and this is dilutional because of water retention. So when your kidneys are not working properly, you will have water retention. Your kidneys are not able to filter things out and make urine. All that fluid stays in the body. The waste stays in the body. The electrolytes stay in the body. The toxins stay in the body. All of that builds up. You're not able to properly filter out your potassium, your phosphate, your magnesium. They build up high. Phosphorus levels being high decrease the level of calcium, so that goes low. And overall, your sodium, which is the electrolyte that is most influenced by changes in fluid balance, goes low because of dilution. It's because your sodium is outside of the cell, exists extracellularly. So it is most affected by fluid shifts. So you have that hypovolemic versus hypervolemic types of hyponatremia. But in this case, you have dilutional hyponatremia because you have so much fluids that even though this number, uh, that maybe this number didn't really change, there's so much fluid that it dilutes it. So think about a glass full of sugar and you add a whole bunch of water into it. Even though the number of the amount of sugar you placed on in it is the same, you diluted it so much, making it less sweet because there's so much water. Same idea with the sodium. Okay. Any questions on everything we just talked about so far? Okay. Something else I wanted to bring up is the calcium, alongside not just the phosphate, which binds to the calcium. So typically the phosphate binder is the calcium acetate that you will take with food, and they will bind to the phosphate in the food to try to decrease the levels of phosphate. Don't worry, I had to look it up too, Galen. I couldn't remember the name. It was calcium something. Um, and alongside the fact that your kidneys again activate your vitamin D, and if you're not having a proper vitamin D levels, then you're also having a harder time absorbing calcium. But there's also a relationship with low albumin levels as well. And you don't have to know the patho behind it. I could explain it if you guys want, but if no one cares, then I won't. But just know low albumin goes with low calcium. But there's a caveat to that, and that's that it will make your serum calcium level low, but it might not actually give you hypocalcemia. But I will not explain unless you guys want me to. Someone say yes. Someone say. Did someone say yes? They want to know. They want to know. Behind what? Oh wait, are you pretending or like did you mean it? Oh, okay. So, sure. So if you've ever had a kidney patient, yeah, so the TLDR is that calcium exists in two different forms in the body. It exists as a free ion, so that would be your calcium 2 plus, and it also exists binded to albumin, where it's essentially a backup reserve. Your serum calcium is a combination, is the total of your free calcium and your albumin binded calcium together. When your albumin levels are low, your body then chooses to release less calcium from the bones because, like I said, that albumin bounded calcium is essentially a reserve. So if you don't have enough albumin, your body says, okay, well, if you don't have enough albumin, then we're just going to release less calcium. So you will have less essentially in reserve, but your body keeps a really tight control of your free calcium. So when your albumin levels are low, you have less of your reserves, but that will cause a decrease in your total serum calcium. But your total, or rather your free, um, biologically available calcium will be normal, potentially. So there is a formula that you can do, and if you want to be really smart and clinical, your corrected calcium is equal to your serum calcium plus, yeah, Miss Fletcher. Well, she didn't ask me. I learned this from one of my teachers, and then I said it to to my teacher. I'm like, yeah. It actually came up in preceptorship. I had a patient where this came up, and then I told the nurse about this, and then the nephrologist came in and said the same thing. I'm like, yes. So this is the formula. You also don't need to know. This is just extra information. But if you've ever wondered why someone maybe has like a low calcium level, but they don't have any signs and symptoms of hypocalcemia, or they're not getting their calcium corrected, it's because their calcium level was probably technically normal. So for example, someone with a 7.9 serum calcium, a normal range is like 8.5 to 9.5. Their albumin is like 2.2. If you do the math on this, it ends up being, let's see. And again, you don't need to know this, but if you decide to bust this out in clinical, you'll look super cool, I think. It would be this plus that. It ends up being 9.34. And then you compare this value to your normal range, and this is normal. So in that case, that person with the low albumin technically has a normal level of calcium, which is why they don't have signs and symptoms. So the ratio is technically right, but the levels are wrong. What do you mean? Ratio is technically. Oh yeah, kind of. Essentially, your albumin influences your total count, but it doesn't mean that the body is lacking calcium because it's difficult to separate the calcium your body actually uses versus the reserves it has in the blood. Yes. Yes. So when albumin is low, your total calcium in the blood will be lower because that's the total, but the amount that is biologically available, it can be normal. That's basically what that means. But again, extra info. But I like this formula. It's fun. But again, don't worry about it. It's just patho for the correlation, and that might explain some things that you might have seen in clinical. Okay. So next, the kidneys will regulate pH. It can retain or waste bicarbonate, and it can also eliminate your H plus, which is your acidic. So it has a huge role in acid-base balance. So if you have kidney problems, then we can imagine that you will have metabolic acidosis build up from inability to get rid of um, acid and use your bicarbonate. Your bicarbonate being, if you recall from your ABGs, what the body uses to buffer against acid. So when impaired, metabolic acidosis possible. That's one of the reasons that can cause metabolic acidosis. Another function of the kidney is in the stimulation of red blood cell production. So we know erythropoietin. I think he told you guys to know the synthetic version of it. I think Epogen. Yeah. So this is going to cause the stimulation of the stimulation of the red bone marrow to make more red blood cells. So that's something your kidneys can do. Which is why when your kidneys are impaired, it will slowly lead to chronic anemia because your kidney is not the sole thing that causes red blood cell production. There are other organs. So your red bone marrow is the primary thing that makes it. Your spleen in emergencies can make it. Yeah, this is what I used to describe it was the kidney is the manager that tells the bone marrow to get back to work. But the kidney themselves has no, like the kidney themselves is the manager, the supervisor, but it's not actually doing any of the work. He's not like the manager is in the factory. He's not the one actually making the products kind of idea, but he's telling everyone what to do. So it's gonna be a little bit slower, but it can lead to chronic anemia. Okay, so from all of this, that's everything with the kidneys in terms of the pathos summarized. It's a little bit more in terms of like the nephrons and stuff, but don't worry too hard about that. Just your nephrons are your units that filter stuff out. Um, your body
Remember my
gets rid
tutor
of
session? I forgot we have a tutor session.
urea, creatinine, H plus, electrolytes and stuff. But this is everything you'll see. So again, summary, kidneys go bad, hypertension. Kidneys go bad, electrolyte imbalances, drug toxicity. Creatinine, BUN go up. Calcium goes down. Here's the electrolytes again. Anemia, likely. Acid-base balance, likely to be acidic. Now, questions for you is what should we not see in the urine? What are things that are not normal to be in the urine? Yeah, so RBCs, we don't expect that to be. That's called hematuria, so that's not a good thing. Protein, specifically, you can see things like albumin. So that's one of your first things, and glucose, yes. So your proteins, including your albumin, that might be a sign of early, um, what's the word? What's the word I'm looking for? Early kidney impairment. So we talked about that when it came to diabetes. So early kidney impairment would be the albumin leakage into the urine. Glucose, so someone that is diabetic. Yeah, the albuminuria. And then the glucose, someone that's diabetic, they might have um, glucose seeping out the test they do early. I think so too, yeah. The albuminuria. I think so. Yeah, so probably do that. So that's the one, microalbuminuria. Microalbumin and yeah, and then glucose and some other things when it comes to like decay, the ketones, although I think there can be a small little bit of ketones that's just naturally in the urine, but having a high amount of ketones in the urine is also not a good thing. So like high level of ketones is not normal either. Okay. Alrighty. So now I want to ask in particular, when it comes to your diagnostics, what are some things that they could do to kind of assess and look at what's going on with um, with that? So diagnostics slash labs, because we talked about the urine, so we can assume a urinalysis is in there. What are some of your labs? Yes. So your creatinine clearance, yes. This is the most accurate way of determining your urine, sorry, uh, your kidney function. Urine output, sure. So like a urine output. GFR. And typically the GFR, um, you'll see in the labs the eGFR. That's the estimated one. Yeah, this is an estimate, so it's not fully accurate, which is why your creatinine clearance is the most accurate. The specific gravity, that could be something, especially because there's a little thing that we can talk about when it comes to the specific gravity that is pretty interesting when certain things are off with the kidneys. So BUN creatinine, and then serum creatinine. Serum creatinine's different from the creatinine clearance, technically. This is how much is being let go in the urine. This is how much is left in the blood. In terms of purely just, sure. Kaylin wants to ask, how do they do the creatinine clearance testing? What method is done? So how long is it being collected? Yeah, that you get a big ass bottle. Honestly, I think I could do more than 3 liters personally, but um, yeah. So this is gonna be, yeah, it's gonna be a 24-hour urine collection. Is there anything you would like to tell them, or I guess the nurse would be keeping in mind when it comes to the 24-hour collection? How do you how do you start? Yes. Yes, so you discard the first void. So that's discard first void and then collect from there. Perfect. And there's some other things like you put it in ice to prevent bacteria growth, blah blah blah. Yeah, that makes sense. Yeah. Empty the bag and begin. Um, although I believe from when you're getting it from the Foley, you don't get it from the bottom part, you get it from the middle of the tube. So you clamp the tube to have yeah, you have to clamp the tube so that the urine builds up and then you access it from the little port. Yeah, stays yeah, quote unquote sterile, even though yeah, that area is not sterile. Well, I guess it kind of. Man, I've gone so good empty in the flood. Yeah. You're at Rancho, right? Yeah. I thought you guys saw a lot of stray cats there. Like that little stray cat little bag thing. Oh, interesting. Okay. What are you asking, Kalen? Possible chronic retention from injury? What question was that? Oh, 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 from spinal cord injuries. Okay, sure. Okay, so let's just go over some values real quick. Um, what's a normal value for your GFR slash your creatinine clearance? Yes. So creatinine clearance normal is 85 to 125. I think it's ml per minute. And your GFR, your GFR is the same thing as your creatinine clearance, but your eGFR is technically different. This is an estimate. So it does have it has a similar value. I think it actually technically has the same value, but it's not as accurate. So just keep that in mind that the eGFR is not as accurate as the creatinine clearance. But it will follow essentially the same relative number. Oopsies. Okay. Then we talked about urine output. So what's a normal urine output? Sure. So we can say 200, 400 ml a day minimum. What about kind of like a ratio in ml per kilogram per hour? Yes. So at least, you could say 0.5 to 1 ml per kilogram per hour. I think closer to 1 for adults. But that's considered normal. Another way to think about it is 60 ml per hour. Yeah, under 400 is oliguria. Yeah, roughly 60 ml per hour. But this is a more accurate one right here. This one's the most accurate one. This is just your minimum for the day. And under this, you could be like, okay, that's all like urea, but this is the number they go with a lot. Yeah. So different values, but those are all good to know. In general, when it comes to the specific gravity, we know that less, like a number that's smaller, it means it's more diluted. A number that's bigger is going to be, God, I hate finding this thing. There we go. More concentrated. What is the serum creatinine normal and is it the same as clearance? No. So the serum creatinine, difference between creatinine clearance and serum creatinine means it's in your blood. Creatinine clearance is how much you're releasing in the urine. So serum creatinine is going to be, yeah, I would say closer to, depending on where you are. I've seen zero point 0.7 to 1.1, 0.6 to 1.2, different values for different facilities. Around that ballpark, yeah. I think in the notes it said 0.5 to 1, but I've never seen it that like that. I've seen, I think I've usually see this much, but somewhere around that general ballpark. Somewhere around that ballpark. It will definitely be different depending on um where you are. And then specific gravity, Ryan already gave us the number here. 1.00. I think she said in her notes like 1.003 to 1 point. You'll see different values for this one as well. I'll just go over what she has on her thing. I think that's what she has on her thing. I've seen Kaplan will have it as 1.005 to 1.035. And then this notes will have this number. We'll just go with this one. BUN, also you'll see this completely different number depending on where you are. Here they say 10 to 20. I've seen some places where it's like 8 to 22. Stuff like that. It's always going to vary drastically, but as long as it's within the same ballpark, it's fine. Yeah. But like we mentioned, the BUN is more determinative of hydration level. You can definitely have your BUN high from being dehydrated because you're not peeing, so the urea nitrogen's being um, stuck in the blood, essentially, without having kidney damage. Yes, so we will look at that soon with the BUN creatinine ratio. Pretty sure it's somewhere over here. Okay. Only other thing that I could bring up here, I think. Let's talk about the map. Your mean arterial pressure. Give me the formula and then also what's the value that we want for this one. Yeah, you want 60 to 70 and up to like 110, Kalen, do you remember if it's up to 110? I think so though. Yeah. Say 60 to 70 plus, well, 60 to 70 till 110 is ideal. 60 minimum, 65, 60 minimum. And give me the formula because you will have to calculate this map. Yeah, 60 is bare minimum. You want closer to somewhere, yeah, somewhere between 70 and 110 is probably better. Less than 60 is bad. Less than 60, um, your kidneys are really struggling. Yeah. So I'll kind of do 60 to 70 minimum up to 110. Yep. Now give me the formula. No one's giving me the formula. You guys will have to calculate this. Yeah, so it's going to be 2 times your diastolic. Let's see if I can write it in a nice way. 2 diastolic blood pressure plus systolic blood pressure all divided by 3. So let's do some. Let's do some. So blood pressure of 156 over 95. What's your map? So make sure you know this because they will not provide you this formula and you will have to calculate this. And remember it for the next class too. About 115, yeah. Yes, so know how to calculate it, know how to apply it. So yeah, 115. So 115 is above our ideal, meaning that now the pressure is a little too big. So too much pressure can also lead to impairedness. So we know that with, hypertension, the pressure is too big, then that could also mean that things aren't flowing as good. Yeah. So 2 times your diastolic blood pressure, add that to your systolic blood pressure, and divide all of this by 3. So in this case, this would be, if we're using this one, it'd be 95 times 2 plus 156, and all of this divided by 3. There it is. Yep. So now I'll give you a different number. Let's say 124 over 184 over 86. Don't forget to divide by 3. Okay, 99. So we like that. Okay, now one more and then we'll move on. 85 over 42. 56. Do we like that? No, that's not good. Perfusion bad. Kidney no like bad perfusion. Kidney, kidney sad. Okay, anything else? Any questions on how to find the map? You will have to interpret this. You will have to know how to calculate this. So you need to know this, and you need to know you need to know all this stuff here. This as well. Under 60, the kidneys are struggling. Kidneys are sad. Okay, any questions on anything we talked about so far? So all of that patho condensed into just this. Although I guess it's been almost an hour, but and all of your diagnostics, all the stuff you shouldn't see, and then we can move on to just AKI, CKD, and then quickly through dialysis. All right, so I gave you guys the definition of acute kidney injury slash acute renal failure. So I think it used to be called ARF. Now it's referred to mostly as AKI. Same thing. So it's a rapid decrease in kidney function, and it can be the prognosis can be good or bad depending on how far it's gone. Depends on how soon you're able to do interventions. So someone with an AKI can make a full recovery, as long as it's being treated appropriately, or that AKI might cause permanent kidney damage. So I've told the story, maybe not to you guys. I'm sure I've said it to you guys too. I had a patient with chronic kidney disease. Um, I come back 2 weeks later, get the same patient again. He's still there, and he got an acute kidney injury in that meantime, and now his CKD. I think he had CKD stage 3. Now it was end stage renal disease, and now he needed dialysis. So he at that time he had just gotten his fistula, and he was getting ready to. No, that was a different person. That guy had heart failure. He came in for exacerbation. This is another guy. Yeah. But yeah, that's why you gotta really watch out, making sure the patient's properly hydrated. Perfusion is good because kidneys are so important. Look how much patho we went over for the kidneys. So much patho for the kidneys. So much the kidney does. Think about why you would rather keep this thing healthy because it does so much. They're little beans, but they do a lot. So there's three types of acute kidney injuries. So there's the pre-renal, intrarenal, and the post-renal. So talk to me what you know about the pre-renal and what you attribute with this one. Yeah, the H's. So what are the H's? There's three H's. So which ones are what are the H's? Yeah, hypotension. So that's where we talked about that MAP under 60. So that's example of that. Yes, so hypovolemia and hypoperfusion. And they sound very similar. They really do. They sound very similar, but I can break it down. So hypoperfusion, oops, kind of like decreasing cardiac output. So this is directly by not because there's not enough fluid, not enough uh just because there's a decrease in the cardiac output. So examples of that can include an MI, congestive heart failure, general cardiomyopathy. So the azotemia that pretty much is like the pre-renal. The pre-renal azotemia, which is essentially azotemia is basically just a buildup of nitrogen and other waste products. Cardiomyopathy, cardiogenic shock, yeah, valve dysfunctions, arrhythmias, basically anything that directly affects heart function. So your heart and your kidneys are also kind of besties, even though the nephrologist and the cardiologist are not. Um, they're always beefing. So hypoperfusion, think about essentially stuff that um, directly affects heart function. Okay. Hypovolemia, we can think about anything that can cause, shock, negative fluid balance, anything that can lead to shock. Hypovolemic, hemorrhagic shock. So trauma, too much diuretics, general, hardcore dehydration. Yeah. Polyuria, so some things that cause polyuria, severe DKA or HHNS, the hyperosmotic non-ketotic, um, whatever this is. Yeah, so diuretics is right here. Hyperosmolar. Is it HHNS or HNN? No, it's HHNS. Hyperosmolar. Hyperketotic. No, not ketotic. What does it stand for? It's gonna bother me if I don't look this. Hyperosmolar, hyperglycemic, non-ketotic syndrome. Okay. What? I had to look it up. I couldn't remember. Oh, you did? You didn't say it. You typed it. I was just expecting there to be a K in here somewhere. I was like, what's the second A? Should there be a K in there? Okay, whatever. Um, and then things that directly cause hypotension. I think the main one here, um, just worry about your map. She gave us an example like sepsis, but sepsis can also be a cause for like intrarenal. But generally, just think of things that make perfusion go bad. Cardiac cardiac output low, that's bad for perfusion. Fluid volume low, that's bad for perfusion. Your map being under 60, that's bad for perfusion. Okay, alrighty. And we can kind of include this for assessment as well. So when it comes to the pre-renal, we have BUN creatinine ratios that we can use to kind of determine things. So what are some what BUN creatinine ratio would you attribute to the pre-renal type? So this one is going to be a BUN creatinine ratio of above or just 20 to 1 plus, essentially. So for example, this would be someone that like remember, like one of your main things is dehydration. So somebody with a BUN like 37 or something with a creatinine of like I don't know, like 1.0, which is technically normal. So 37 divided by 1 is 37. That's above 20. So you can see with, like we talked about, high BUN with normal creatinine. So that's the idea here. This is someone that's heavily dehydrated, but the creatinine is still within normal limits. And their ratio is showing that this seems to be more of an issue with dehydration. Because again, like we talked about, your body will do its best to get rid of creatinine and keep that level normal because it has no purpose. Creatinine has no purpose, has no value. Um, Everybody hates creatinine, so we're getting rid of that one. So that one's being disposed off normally, but your BUN isn't. So that one goes up, this one stays normal. So that's where that ratio comes from. Okay. So that's going to be your main thing for that ratio there. Other things to assess is things such as, uh, you know, I guess it's kind of like this is kind of like a management, I guess. So when it's pre-renal, we're going to do things such as just monitor fluid balances. this person might need boluses or more intake. But also kind of keep in mind those that are at risk for all of this stuff. So it'd be like assess for those at risk, and we talked about those on diuretics, those that are MPO, um, nephrotoxic agents such as antibiotics, aminoglycosides, yeah, NSAIDs. Although I think this one's a little bit more attributed to the intrarenal, but we'll talk more about it. But yeah, the goal is to restore, have down for ARF. Just in general, I think. Well, I mean, this is ARF. These are the three different types of ARF. Oh, no problem. Kidoki. Where was I? So we talked about that. Not sure what the stage is. Guess we'll do this. I'll move this out of the way for now. Because I'm trying to separate them like this. Happy Thanksgiving. Oh yeah, I keep forgetting it's Thanksgiving soon. Yeah, happy Thanksgiving. It's like the second time I forgot. Okay. But yeah, that's kind of how you separate this one and that one. Can you put some examples of antibiotics and aminoglycosides? So I guess examples would be like vancomycin, aminoglycosides. Yeah, I think a lot of them just end in mycin. Let's find out. Ba, 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 da. Gentamicin, streptomycin. There's that one with the yeah with the bond. Probably the most common, the ones I recognize the most out of all of these. I think honestly, I think vancomycin might be a different type. Because I remember there being some where like they all end in mycin, but then there's one that doesn't. Where's the search bar? Yeah, I knew it. Vancomycin's not an aminoglycoside, it's a glycopeptide. But usually it's going to be the ones that end in mycin. And even then, Benko is definitely nephrotoxic. But yeah, but aminoglycosides in particular are like extra nephrotoxic. And then we know your NSAIDs like yeah. Your NSAIDs like ketorolac and ibuprofen, technically aspirin. Okay. So now let's talk about intrarenal. So with this one, um, your intrarenal, this is when you have more internal damage. So we have internal ischemia. And a lot of time that's related to like a prolonged low MAP. And again, that's under 60. So sometimes it can kind of go like this, where you have pre-renal. So our blood pressure is low consistently. That MAP is under 60 damage. And then that becomes intrarenal. Yes. For this one's more attributed to the nephrotoxic agent. I would attribute this a bit more for intrarenal for sure. So all of this. So internal ischemia related to prolonged low MAP, nephrotoxic, again, your nephrotoxic substances. Yeah, your contrast dye as well. So pretty much the same thing, contrast dye as well. And again, like I said, this one's I would attribute the use of nephrotoxic more with the intrarenal. But I think like early on, this can cause some issues with this before it fully goes off the deep end. And then yeah, the Mucomist, he loves Mucomist. He do be loving his Mucomist. So other stuff here, like diseases such as sepsis, can cause severe vasodilation, and in which case we have this really bad um, hypotension, hypovolemia, and this one's so severe it can end up basically going from here and then going to here pretty quickly. But that's kind of why I mentioned that technically the sepsis can go under the hypotension as well. But sepsis, severe vasodilation can cause that damage quickly. So a lot of the time you'll see the pre-renal leads into intrarenal if you don't handle it appropriately. And it's when it gets to that intrarenal that you have the potential permanent damage. Yeah, so about that is I think recent studies show that that doesn't actually do anything. So I don't think they do that anymore. Yeah, she likes that. Yeah. I think our Mr. Robbins talked about it. Oh, you saw it? Yeah, Mr. Robbins was talking about it, how he was saying that Mr. Robbins was saying that they don't really do that anymore, and if you see it, it's probably like an old doctor. Yeah. I'm gonna get some water, Kaylin, if you can entertain them a little bit.
Giddy up, jingle horse, stick like a feet. Yay. I'm gonna just sing Christmas music. I don't know. Y'all have any questions? I know there's been a lot of stuff going on. Ah, thank God. Yeah, you had a double whammy. But yeah, at this point, it's all just okay, like keep up with your clinical and how do I feel about almost finishing nursing? Girl, I'm nervous. I'm not ready. I don't want to go. Yeah, it's kind of crazy. Only 2 clinical days left. And then you guys will be moving into 242 exams as well. Um, yeah, there's a lot of information on cardiac and renal. It's just there's so much that can happen with them. For the exam, I personally had a very hard time with it. I thought that cardiac and renal was my shiz. Um, I still think it is, but I had a hard time with this exam. Um, it's not for the faint of heart, and I was a little faint of heart. But yeah, I think for me, here's the things that I think really screwed myself over. I'm somebody, Brooke's questions are very hard. They're very critical thinky like. So you guys saw from the first exam, she likes to go, pretty hard into critical thinking. Like you have to really sit there and think about her questions because it's not ever going to be like, "Oh, um what medications can you give for hypertension? Select all that apply." No. Mm-mm. Um, you're gonna have to sit and think it through and convince yourself of an answer. But for myself, I had a hard time with I always have a hard time with like the med names. So I am somebody who knows generic names, not brand names. Um, so there was one instance where I think it was like just the brand name popped up and I was like, I don't know what that is. Um, so I was unable to answer the question, which is why I was emphasizing a little while back. I think I did it with your class and second semester recently, emphasizing knowing both names for the med. Because you never know, one or the other could show up, or both would be very nice. But if one or the other shows up, just so you're aware, like this is what this is. Okay, I know what med I need to know. I know what it does. We can answer this question because I did not know my brand name, so that was I believe NCLEX uses both, but I think typically it would be more generic. Um, but yeah, that was like one random question I remembered. And yeah, it's always two very close answers. So you have to, consider. Oh, Diego, you're back. Hello.
Yeah.
I saw you
Hello.
move the screen. Your two very close answers, you have to consider what makes the most sense. If I do this, like if it's an intervention, pie. Thank you. If I do this intervention, what's going to happen to my patient? If I don't do that intervention, what's going to happen to my patient? So thinking about the aftermath of whatever you're choosing to do and which one leads to a better outcome for that patient is usually the deciding factor between the very close answers. At least that's how I think about it, but okay, I'm gonna eat my pie now.
Bruh. You got pie? What kind of pie?
I'll show you guys my pie.
Oh yeah, do that.
Right here. You'll see it. It's my dad said he got it from the bank.
The bank? What?
It's an apple peach pie.
Did you say
Yeah,
you got it from the bank?
I did.
What
Credit unions are great.
the hell? Okay.
Wait, why'd you stop sharing your screen?
So you could share your screen?
I'm not sure. I would just put my camera on.
Oh, but then people can't see it, I don't think.
Oh, I don't know.
Okay. Okay, so let's go with intrarenal. And what about the BUN creatinine ratio for this one? Yeah, so it's gonna be 10 to 1 or lower. So that's kind of implying that your creatinine is so much higher at that point. So yeah, so I don't know. Let's go 37 and like I guess that would have to be like a pretty big number, like 37 with like creatinine of like 6 or something. You take the division and you get a number, you get like 6. Yeah, super high creatinine. Kalen's seen your high score is 7, right, on that. So this be basically someone actively in acute kidney injury, super high creatinine. Yeah, or it's just like really bad chronic kidney disease. Yep. Yep, yep, yep. So that's that for the intrarenal. Probably make some of these more general. This is probably more general here. I'll do like a general after here. Probably a little bit better. Okay. Lastly, we can talk about post-renal. What does that one mean to you guys? We're right here. Okay. So this is obstruction. Yeah. Called post-renal because this obstruction happens in the ureters. So the kidneys, ureters, then bladder. That's how that goes. So you have your obstruction that leads to the backing up of urine from the ureters back up into the kidneys. So that could lead to like hydronephrosis, which would be like your kidneys filled with some delicious pee, I guess. Let's see. Yeah, so here you have an example of what that looks like. Wait, I guess you have grades on it too. I like this one though. So here's the urine being made, flowing like normal. Now there's a blocked ureter. Here you can see the ureter is being blocked by like a kidney stone. So now all of this distension from all the pee there's kind of gathering up in here, and causing kidney issues because that's not what we want. So that's hydronephrosis, and all of this can lead to some damage. So example can be strictures, kidney stones, tumors maybe. So here's the picture again. All right. Yeah, so we talked about assessing those at risk, the three H's. So again, kind of refer back to here, stuff that deals with things that lead to hypovolemia, things that lead to decreasing cardiac output, obstruction of let's see, obstruction of urine flow, so that's the oliguria. Assessment of labs and stuff, which we talked about extensively. Well, I guess kind of extensively. It took us an hour. So I'll just copy paste what I got there. So labs. So again, high BUN, high creatinine, high potassium, that's your normal range. Low sodium, dilutional, here's your normal range. High magnesium, and magnesium high, just like I said, just like potassium high, just like phosphorus high, arrhythmias. Low vitamin D, which also another reason why your calcium is low, because it's got that inverse relationship with phosphorus. Phosphorus high, increased risk of MI, arrhythmias. Anemia, so you have low RBC, low H&H, metabolic acidosis. So again, all those labs coming back. And now, what can we do to manage it? I think we've already talked about monitoring fluid balances. We talked about fluid bolus. So this would be a way to rehydrate and reperfuse. Something that she mentions is that we can do this fluid bolus can also be indicative of the type of cause. So how can that be? Or how can we use the fluid bolus to also kind of get an idea of what the cause is? So for example, you gave a fluid bolus and the urine output is increased versus you gave a bolus and doesn't really do anything, or maybe even the urine output is continuously decreasing. What do you guys think about that? Yeah. So if again, all your pre-renal causes include a lot of things that kind of have to do with low blood pressure, low perfusion, low blood volume. So if you have that pre-renal cause, the urine output can come back or can increase. And then likewise, unresponsive urine output after can indicate an intrarenal cause. Yeah, the ischemic stuff. What else can be done to tickle the kidneys? Big tickler. The diuretics. Yeah, so diuretics. So typically this is going to be IV Lasix. IV push Lasix. And this can help stimulate the kidneys. To stimulate the kidneys. A little bit of Lasix. And when this is typically given, it's also a low dose, yeah. I believe it's also a low dose. For test purposes, go with for test purposes, go with because it's still in the, yeah, like what Kaylin said, it's still in the PowerPoint, so still go with it. The AM. I think if it was in this situation, you just kind of give it. Just I think it's like a low dose. Kind of basically, it's typically done for like pre-renal, but it might, it's just hopefully it works. Kind of like, okay, well you're in pre-renal, let's just hope this works and puts you back to normal. So typically done for intrarenal in hopes of return to normal function, essentially. Let me see how big the dose actually is. Tickle the kidneys. I don't know. I'll look it up later. Just know that's a thing. Um, and then we did talk about the low dose dopamine that they don't they don't really have evidence for actually being effective, but that's the thing. The theory would be that in theory can vasodilate the renal artery at low doses and improve renal perfusion, leading to increased urine output. Positive inotropes. I suppose in theory, yeah, because if your cardiac output is one of the things that is leading to poor the pre-renal stage, then I think that could be something that we could include in there. The positive inotropes. Um, something else. Yeah, put in there. That's good. And then Kaylin, I'm not sure if this was in their PowerPoint, if we learned this after, but calcium channel blockers, and I think lisinopril as well, can also help with decrease proteinuria. Were you guys told that or no? Question for for you guys. Uh-huh. That's something that can be done. It's to help reduce the leakage of the calcium channel blockers. Lisinopril, I guess ACE inhibitors can be good for UP and to reduce proteinuria. I don't think we got this in lecture. I think we were told this by someone else. Yeah, who got that from Salazar, who is a cardiac MP. So it makes sense that she would know this. Yeah. That's just like extra info. So these hard meds can be helpful for reducing the proteinuria. So even though like lisinopril, we have to assess for the potassium um in the blood, you'll still probably see a kidney person with lisinopril because it can also help with the proteinuria. So it ends up being like risk versus reward. kind of thing. So that's something. Okay, that's basically that in terms of this. Yeah. They also have Lasix. True, that's true. So it's kind of like a catch, like they're on, like I said, like multiple 3 to 5+ antihypertensives. Okay. Yeah. Okay, we have different stages for AKI as well. So you have the oliguric phase, the diuretic phase, and the recovery phase. Yeah, so that's another key thing is that before dialysis, you want to hold blood pressure meds. We'll get to that in a little bit. So this is where you kind of have that, so you want to assess for the 1 ml per kilogram per hour or less than 400 ml in 24 hours kind of thing. Be less than 0.5 to 1 or less than 400 ml in an hour, 24 hours. That can be the sign that you are oliguric. So this one in particular, especially, is the minimum urine output needed to excrete body waste. So, and then you're going to be doing other things like, assessing BU and creatinine ratio, assessing your 3H's, oops, all of that stuff. Okay. And that can determine the true treatment again. So if your BU and creatinine ratio is 20 to 1 plus or more, attempt to give your fluid bolus and stuff, give fluids, encourage fluids, and then again 10 or lower. Consider doing the IV Lasix. This is hard to reverse, so low dose dopamine because that's what we were taught for this, so kind of just follow it. If not responding to treatment, that's when you have I don't know if she gave you guys this in class, the AEOU, your acidosis, electrolyte imbalance, your intoxication due to meds, overload, and uremia, so uric acid buildup, and you're gonna end up with like dialysis. Oopsies. Okay. So you'll see the overload is definitely like a very big deal. So this person will likely definitely FBO high risk. So you need to do things like assess for what are we assessing for when someone has fluid volume overload? Some things that when we're retaining and stuff. What are we looking at? What are we worried about? Sure. So we'll talk about BP map. Anything else? Yes. So lung sounds. So crackles, coarse crackles, whatever we got building up in there. Pulmonary edema, general edema as well. Just edema in general. Electrolyte imbalances because fluid shifts as well. So what's we talked about this, so let's see what you remember. Which electrolyte? Yeah, diluted sodium. Yeah. So what's a level where we're really starting to worry about that sodium? Because sodium's typically like, oh, if it's 130, if it's 133, it's like whatever, I guess. Under 130, you gotta worry a little bit more, and then treatment probably starts like under 125, and then around 120, that's when the risk of seizures get extra hard, and the sodium is gonna lead to like neurological like deficits. It almost looks like they're having a stroke. Yeah, you'll talk more about that with that. Like, especially sodium. So here, but keep in mind, of course, your potassium, your phosphate, your magnesium, all of those elevated are dysrhythmias. Think about that. Arrhythmias. So like 125 or lower. There you go. There's like a really cool thing that she mentions in terms of the um what's that thing called? The specific gravity. So it's pretty cool. I think it's cool. Does anyone remember? If not, that's okay. It's 1.01, and this is the specific gravity. No, kind of. This is the specific gravity. Yeah, probably more like intrarenal in particular, but yeah, I'll probably say can instead of will. Specific gravity of your plasma. Essentially,
I was
oh, go ahead.
I was gonna ask you because oliguric would be super concentrated because they're not peeing, right?
In this case, this is probably more like intrarenal. So this is the kidney damage is so bad that your kidneys literally cannot concentrate anymore.
I remember that, and then I believe that was also true. Correct me if I'm wrong, if it was also true for the diuretic phase, where it's just coming out as 1.01, like a set number.
I don't know if it's mentioned. Let me look this up.
At least let's see. On our side, we have for intrarenal slash chronic a UA of 1.01.
Mhm.
And then for pre-renal and dehydration, in oliguric greater than 1.030. Oh, my computer's struggling. I have so many tabs open.
No, I'm getting that it's more likely in the oligar phase. If it was working normally and if your kidneys were working normally and you were oliguric, it'd be really concentrated because it's still trying to get rid of waste. But in this instance, the dam like really damaged. Like the kidneys are so damaged they can't even Because that's why the waste stays in the body, because you can't even like concentrate the you can't even concentrate the urine. Um, and there is significant damage. The
Oh, I see.
kidneys cannot concentrate urine.
Okay, I'm understand. Oh, the longer the stage of oliguria, the less likely patients going to return to baseline. Watch for FBO. If pre-renal oliguria, urine will be concentrated because the urine output. If it's intrarenal, kidneys can't concentrate it.
Oh, that's from your notes. Yeah, it says right there. It says if it's intrarenal oliguria, kidneys will no longer be able to concentrate. Urine specific gravity is plasma. Oh, I see what you're saying. The distinction between the pre-renal. Sure.
Yeah, because
Let's make
on
that
there,
distinction, yeah.
yeah, from there it says pre-renal oliguria will be super concentrated, but if it's intrarenal, your kidneys are the big damage, and then that's when you get the,
Yeah.
yeah. Because I was like, wait a minute.
Sure, let's break this down. Oops, I did it again.
Oops, I did it again. Oh, don't yawn, you're gonna make me yawn.
I'm yawning, bruh. Yeah. Oopsies. Oopsies. Yeah, because with the pre-renal, you don't have that damage, so it'd be like high specific gravity. It's concentrated. Intrarenal, it will be 1.01. Yeah, essentially. It's basically yeah. If it's pre-renal, there's no kidney damage per se. So your kidneys are, you know, they're lagging behind, but they're still functional and
Yeah.
you know, they're able to concentrate. But when there's intrarenal damage, then the kidneys and it gets to like a really bad point, then they're able to um let's see. I'll do it like this. Boom,
Yeah,
boom,
I was gonna
boom.
say because like the pre-renal, one of the causes is hypovolemia, right? Like you're
Uh-huh.
dehydrated
Yeah.
essentially. So I think like, okay, I go throughout the whole shift, I drink 2 sips of water and I go to pee, like I pee 12 hours later and it's like super concentrated.
Yeah.
So I kind of apply that there if that helps anybody.
Yeah. Granted you don't have an AKI in that case, but yeah.
Oh, at this rate, I might.
But yeah, so
That was a
that's the
pretty laugh,
distinction. So thank
thanks.
you for catching that. The distinction between when you have significant damage.
I think that was something that tripped me up too. Because
Yeah.
that specific gravity really confused me.
Oh no, totally. Yeah. So again, just to reiterate, pre-renal damage is not really there. So you'll have a high specific gravity because it's concentrated urine. But when it's intrarenal and has heavy damage, when there's significant damage, the kidneys cannot fully concentrate it. So it just has a consistent specific gravity of 1.01. So we'll do that. So that should make it more clear on that. Okay. So then the diuretic phase is essentially, is this a good thing or a bad thing? This is a positive sign that progress is being happening. Positive sign that the kidney is healing. The kidney's basically like, it came back home with the milk and it's like trying to make up for it. So he's like hanging out with the kids more, you know, just to try to be like, oh, I was gone for like 10 years, but like I'm back. Let's go to the park.
Dude, no, 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 no. Queen.
Yeah, it's like a really long line for milk. Yeah. So essentially the kidneys are like then super like they're peeing so much it can be really unconcentrated. They're just like yeah. What? Wait, why you say I'm getting cold for Christmas? The milk, yeah, he's getting the milk.
Yeah, but you can then kind of go the what? There's so much you're diuresing so much, you're getting rid of so much fluid in attempts to make up for lost time, and you can risk dehydration going right back into oliguric phase. So you got to be careful with this. This is where your kidney patient is might be placed on IV fluids and stuff to make up for the diuretic phase of the AKI. So it's a positive sign that the kidney is healing. Um, there will be a lot of urine output, although it might not be well concentrated. So think of that as good quantity, poor quality. But you also have a risk of dehydration since the urine output is high. We do not want to go back to oliguric phase. So assess for that urine output.
He's going back for the milk. So Jover.
Yeah, you don't want him to go back for the milk. So yeah, we don't want to go back there. We want to assess for the urine output. Continue assessing for the BU and creatinine ratio. 3 H's. Putting ratio on. Ratio. See, you liked it. You liked when I said that. You thought it was funny. And then the recovery phase, so they're 2 hours, I don't know why. This is a gradual return uh back to normal and can take up to a month, like you guys said. That's kind of how that goes. Oliguric phase, everything's going down. If we have pre-renal, try to give them IV fluids. Try to get the kidneys to start making urine again. If the BUN creatinine ratio is low, intrarenal, this is when it gets harder to try to correct it. We can try doing stuff with the IV Lasix. You can try the low dose dopamine, manage the symptoms and everything. If they're going into that oliguric phase, the high risk of FBO, so you got to really assess the lungs, the MAP, edema, electrolytes, all the symptomatic stuff that could happen. Some interesting things with the UA, with the intrarenal, is that it can show the specific gravity of plasma. And then a positive sign is once you go from making low urine to making a lot of urine, that's the diuretic phase. But you also know that this high quantity of urine is not properly good concentrated, so the quality's bad, and you don't want to be dehydrated again. So you need to provide proper fluids, assess for urine output, I's and O's in general, BU and creatinine ratio, and hopefully we get that recovery phase where the urine output starts to come back to normal. But it requires, all that proper management. Another thing for, I guess, for management, monitoring the fluid balances. That's going to be your daily weights and stuff. She says that the weights are the strongest indicator of fluid balance, even though no one ever takes them. Ozempic. Daily weights, yes. Strict eyes and no. This person might be, depending on what's going on, you gotta watch out for all that retention and stuff. Another thing here. So I don't want to make it too confusing here, but fluid restrictions if they're in the oliguric phase. Oh, yes. So that is essentially you take their 24-hour output, add 600 ml for insensible losses, and that's their total equals the allotted intake for the next day, essentially. So maybe I'll refresh. Oopsies. Yeah. So that's how you can try to make sure that they get the proper fluids without going too crazy on increasing the FBO. Okay. Any questions on AKI? This was longer than I thought. No? Okay, cool. All right, so then there's chronic kidney disease. Definition, main thing to know is that this is progressive and irreversible. Bum, bum, bum. Mm, 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 mm. The main causes, same thing. It's always them. DM, hypertension, hyperlipidemia. It's always them. And the stages, someone already linked them, or someone already posted them. I'll just re-click here. This is basically based off your GFR, and when I say GFR, I don't mean eGFR. I mean the creatinine clearance. That didn't come out exactly how I wanted it to, so let's do this. Something like that. So just kind of the general idea is that end-stage renal disease dialysis is very likely needed. I have seen people that are technically ESRD that didn't have dialysis and were still able to make urine. But a lot of the time, people with ESRD can't make urine anymore. Stage 4, they can consider dialysis. But a lot of nephrologists will do everything they can to prevent they're like not have to make the patient have to go through dialysis. So some kidney doctors will see that you're making urine and they'll try to work with that. They'll they'll try to make every little nephron work until they can't. Okay. When it comes to manifestations and assessments, it's basically the exact same thing. Really not much different in terms of everything really. It's about the same thing. Someone mentioned uremia. Yeah, so that's another thing that can build up is the uric acid. Well, uremia is I don't know what's it, the urea nitrogen stuff. Um, that's probably, yeah, it's probably going to be a bit more prevalent in this one just because the high buildup of uremia, just like the high buildup of ammonia can cause confusion and other stuff like that. Uh, I like this picture, so I'm going to post it. This one lost its thingy. Why you like this? This is a nice picture. Chronic renal failure, and it shows some of the things that can be associated with it. Oh yeah, yeah, this one's nice. I like this one. Includes a lot of stuff. Yeah, she does not look okay. She looks like she really went through it. Yeah, maybe we can talk about that in here. Boom. Yeah, it has everything on there. I like the picture. It's cool. It's nice. Um, yeah, whatever. I think this picture's fine. So general management for everything. Uh, yeah, just list off everything you can think of, and I'll write it down. This one's gonna be different. This is where it kind of does differ. So a lot of your signs and symptoms are very similar. Very similar. Mostly the same as AKI signs and symptoms. But more long term, because it's long term, it can lead to some other stuff and affect other systems. But in terms of like your labs, you'll see relatively the same thing as you will with the AKI, but now it's chronic. And the consequence of chronic liver kidney impairment includes all of this stuff here. Lots of retention, chronic anemia now, confusion because of the buildup of uremia, uric acid and urea nitrogen, your really high blood pressure, pulmonary edema due to retention, nausea, vomiting, as it mentions here, bone pain because of the lack of calcium, probably have like some heart palpitations and other stuff, all sorts of stuff. But yeah, I'm gonna go to the bathroom real quick. Any management you guys can think about, medications and stuff. And Kaylin will I don't know, keep you guys entertained again.
Oh God. Lord help me. Let's see, I think Benadryl was one of them. That sound right. Oh yeah, it's a phosphate binder. Yeah, that's right. Y'all, I've been Christmas shopping here. Forgive me. Honestly, this one really screwed me over. This, in my opinion, this was the hardest one. Diego thinks that the first was the hardest one, so we have different opinions there. I'm trying to think on that. I felt like I got tripped up, and I was looking too far into the questions. I think that's what really hurt me at the end of the day. Because I remember, like, let's say that there was like a question on MI. Let's say that you get a question on MI, and it's like, oh, like, what are you gonna do? Select all that apply. And like, you guys were taught Mona or Awanum. Um, but I remember them saying like, and Nitro as well. And they were saying like, oh yeah, if the patient doesn't have like a low oxygen sat, like you don't need to put the oxygen on. So like I got to that question, I'm like, do I need to put it on or do I not? Because like in the PowerPoint, it was saying Awanum still. And we weren't given any oxygen saturation that was discussed in today. Oh, jump scare. It's a good thing you had sim today then, right before this exam. Um, but yeah, I looked too far into a lot of the questions, and then I was like questioning like, oh well, but I remember them saying this, but then in the PowerPoint it said that, but then when I looked it up online it said that. So I was like all over the place. I was looking way too far into it. I was overthinking it, and that was what really hurt me at the end of the day. So don't be me. Don't do that. Take your time. Don't add to the question. Take it at face value, etc. For your if, how do I say? I think I would specifically ask because Salazar was the one that did that one. I think I would specifically ask her, um, just to ensure that that's how she would like to test you guys. Um, but yeah, because like technically Owanum is the acronym, but at least in our class, she said in a comment, like, oh, like you don't really give oxygen unless you really need to. Yeah. Um, so it definitely was case by case, but just I don't know. Always just kind of clarify what they want. Yeah. I just like I said, I really just overthought a lot of stuff and I really hurt myself because of that. Now on a happier note, did y'all know that Snoop Dogg has a cookbook, a recipe book from Crook to Cook Platinum Recipes from the Boss Dog's Kitchen? It's on sale right now at Walmart.
Why are you advertising?
I don't know, I just found it. He's besties with Martha Stewart?
Wow.
What? I did not know that. Yo, that's crazy. Snoop is everywhere at this point. I don't know how he gets into half the stuff. He's from Ryan's Hood.
Ryan? The only Ryan oh, Ryan. Oh, I don't know why I was like Ryan. What do you mean from Ryan's Hood? I don't know why I thought like Ryan's toy review when I saw I'm like Ryan's Hood. I'm like, what?
Girl, what?
You know, what was the name? Wasn't his name? What was his name?
Who?
The little kid that always reviews toys.
I don't know.
You know what I'm talking about, right?
I don't.
What?
So that's what you watch in your free time?
No, but it's like it was everywhere.
I
It's
don't
like
know.
it's like the Coco Melon.
Oh God. No, I don't know it. I'm sorry. I actually genuinely don't know it. Good times.
Okay. Anyways. Yeah. So what? You guys didn't say anything. Okay. Um.
My
Are
bad.
you? Oh no, no problem.
Josh said Renagel.
Oh, nice.
Earlier he did say that, and then I started talking about random stuff, and then I started
Oh,
talking
the
about Snoop
phosphate
Dogg.
binder. Okay. Okay. So let's just kind of break it down. We talked about antihypertensives. I know you guys know that.
Yay!
Diuretics. We talked about this.
Yay!
So loop diuretics,
Loop.
and they also help to waste K and magnesium. What else are we talking about? Calcitriol. So that would be, yes, calcitriol, which is the active form of vitamin D, which we mentioned that we're lacking. Iron and folate. Iron and folate. Iron folate to treat anemia because we have chronic anemia.
Oh my God, it's a little tree.
Erythropoietin, aka Epogen, um, can also be done because we don't have to give blood transfusions or whatever. We can iron, folate, erythropoietin. Um, yeah, we talked about phosphate binders. So this could be stuff like the Renagel that Josh mentioned, the calcium acetate. This is Foslo. Calcium carbonate, which is Tums. Tums.
Dum, 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 dum.
Yeah. And most of these are calcium based, so that helps to also kind of make up for the calcium um that is low in these people, in these human beings. Vitamins. Yeah, like a good combination of vitamin B and D to help with the calcium intake and whatnot. I'm tired. What else did we mention? Boop, 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 boop. If we have uremic acid buildup, then allopurinol. Um, we manage uric acid. Urea buildup. Too much of uric acid, too much urea. Confusion. So ammonia, protein broken down to ammonia, too much of that confusion. That gets broken down into urea nitrogen to be dumped, but if it's built up, also confusion. So you can't win. You can never win. Yeah, just stuff like that. You'll see these people on a lot of antihypertensives, so they'll probably be on like 2+, 3 to 5. Lots of them. They'll be on lots of them. Long term, they'll be on loop diuretics because these people have chronic fluid retention. And we don't want that. It also helps with of course, with the blood pressure, but also we don't want them to have fluid in the lungs because that's bad. Breathing good, fluid lungs bad. Yeah, so we want to avoid things that are going to be nephrotoxic. So NSAIDs are probably not the best idea with these people. Yeah, yeah. Anything else that I'm missing from here? Let's talk about diet actually. Let's do that. So what are the diets looking like? Oh, my bad. What's a renal diet consist of? It sucks. It's basically like yeah, it's like
Yeah, mine as
hell
well.
on earth. Yeah, it's the worst thing ever. Includes like a fluid restriction, a protein restriction, like everything. Salt restriction. You can't have anything. Yeah, you can't even have water, bro. You have fluid restriction too. It's over. What do I do? What can you even eat? It's horrible. Yeah, it really sucks. I would never want this to happen. It's the worst thing of all time. I think a lot of the people that I've seen with ESRD also ended up having tube feeding, so they were just on the Nepro, and that's their nutrition. They had like a J tube or a peg tube, whatever. Yeah, high potassium foods, potatoes, bananas, tomatoes, kiwi, citrus, mango, salt substitutes. Yeah, that's good to keep in mind. I'm gonna copy paste it. Salt
Yeah.
restriction, restrict. Okay. Phosphorus in foods. Here's this. That helps. Yeah, it's good to know. I don't know if it came up on the test, if I'm being completely honest, but if she's emphasizing them, I'm sure I was. Anything else to add on, Kaylin? What do you think?
Huh?
Oh, I asked if there anything else you think could be added on.
For management?
Yeah,
Yeah.
yeah.
Sometimes they can have, what is it? I always forget what the buildup is, but causes itchy skin.
Oh yeah, that's the phosphorus buildup.
Okay, so you could put stuff on the skin to make them less itchy, keep them
Sure,
moisturized.
it kind of goes with this as well. So phosphate binders can also help to decrease itchiness. There's another thing, what's it called? SSRIs can actually help with itchiness as well with kidney people.
Oh, I remember that. But yeah, for phosphorus binders, I have calcium carbonate, calcium acetate, and then Renagel.
Hmm.
Something to note specifically with calcium acetate, which is your Foslo, you have to take it with food for it to take effect
Mm-hmm.
because it binds the phosphate in food. So
Yep.
take with food. Yeah.
Alright, anything else you guys can think about when it comes to management? Let's do an avoid. How about that? Let's do avoid Renagel on empty stomach. Oh, I did not know that. Avoid nephrotoxic drugs. We already said that actually. So you guys are good. You said we kind of already said NSAIDs in that. No, yeah, over-the-counter antiemetics, antacids, because they can lead to magnesium toxicity. In terms of diet, insulin, I guess what's the word for it? Diet assess for, yeah, hypoglycemia because the kidneys, basically when your liver bad, hypoglycemia, kidney bad, hypoglycemia stays in the body longer. Yeah. Yep, insulin is held on for longer. Yeah, don't use Demerol because the byproduct stays in the body longer. Cool. Avoid Demerol, yeah. Okay. I should be pretty good on that. A lot of the same stuff. And now we can do dialysis. Here's a definition I wrote, or copy pasted, I don't know, one of the two. Don't worry too much about the definition. You know what dialysis is. You got it. When it's typically done. Typically, again, we set the stage 4 chronic kidney disease, dialysis, when certain conditions are put into place, like persistent hyperkalemia, probably above 6 EKG changes. You need like really like you're having like really bad hyperkalemia, EKG changes, and dialysis is indicated. Maybe also creatinine above 5. I don't know why I wrote dialysis here. I meant ESRD. Yeah, that's kind of that. Don't focus too much on the patho of dialysis of like, oh, the dialysate does this and the blood does this and the exchange does this. Don't worry about that. Mostly just know the difference between hemodialysis and peritoneal dialysis, why you would do one over the other. So hemodialysis can have the AB fistulas and grafts. What do you assess for with the AB fistulas? Yeah, so you're assessing for the bruit and the thrill. So the bruit is um you know that one's the sound and the thrill is the, yeah. Bruit's the sound, the thrill is the little movement, the little pulse. Yeah, it could be a sign that the graft is either really new and has it fully developed there, or just it's messed up. In terms of the um accessing it or anything, don't worry, you don't have to worry about it. So the dialysis nurse will worry about it. you don't access it though. That's if it's being accessed, you don't touch it. The dialysis nurse will touch it. So complications, what are we not doing when someone has an AB fistula? Yeah, we are definitely not doing BP, no BP or NP, no BP or lap draws on that arm. So, or whatever limit is, we're not doing that. So make sure you're not doing that because that can mess up the AB graft and ruin it. So assess for infection and stuff. Or clots, so all the general stuff with like things that you could expect with something like this. Infection clots. And then assessing the bruit, which is the one you can hear. Feel for thrill or palpate. But not too hard, I would say. Just like slight touch, you'll be able to feel the little thing. Yeah, this is faster, so that's another thing that's not interesting, but it's good, is that it's faster. But compared to the peritoneal is more in you get more independence with it, which is nice. What are some considerations on certain things? So does the patient have to eat? Yeah, they can eat. There's no issues. Patient does not need to be MPO, so whatever, that's fine. Can you give them insulin? Yeah. We can do acute checks and give insulin. That's fine. Are we holding any medications? Yeah, you want to hold the BP meds. Most meds you want to hold, but especially we want definitely. Like my brain cannot spell definitely, so I'm just gonna definitionally. That's not the word. Definitely, like that, right? Yeah, definitely hold BP meds. So that's gonna be key with that. But a lot of medications should be hold because they'll just end up filtering out. But in particular, hold the BP meds for sure. That's key. So that will probably be a question or something like that. Okay, in terms of complications, main things I think you should focus on are, yeah, they won't get the benefit because you'll end up filtering out through diacylate anyway. General, you want to assess for the fluid balances, and then the disequilibrium syndrome. Those are the two main things to worry about with this thing. Other stuff like blood loss and whatever infection, that's there too. So probably just blood loss, but we're gonna talk mostly about the other two. So fluid balance, you're gonna want to take a wet weight and a dry weight. So wet weight, this is before dialysis. And a dry weight, which is after dialysis. So again, your weight is supposed to be the best indicator of fluid volume. On these people, they actually do the weight. On most other people, they just kind of don't. And just the main thing is recall that 1 kilogram is equal to 1 liter in terms of weight. And you're gonna assess vital signs, of course, pre and post. Was anything given during dialysis? And yeah, pretty much that. So weight before, weight after, how much weight was actually lost? Vital signs before and after. Was anything given? Uh, yeah, exactly. So was anything given? Anything for, did we need to stabilize? You need to stabilize the blood pressure. Anything need to be done in terms of that? Disequilibrium syndrome. This happens due to the rapid exchange of electrolytes due to dialysis. So this is going to lead to increased ICP. So what goes with that? You have altered level of consciousness, nausea, vomiting, headache, restlessness. You can have seizures from the electrolyte imbalances. So this is a life-threatening position or a life-threatening condition. You have to call the doctor. Call the doctor, head of the bed up, give them O2, take vital signs. But this is your key thing here. That one. Protamine sulfate. For heparin? Or what about heparin? Hmm. Wait, what? Why heparin? Like, why? Whatever. Oh, that I did not know.
In the dialysis solution?
Are there? I didn't know that.
Makes sense because you're sending blood through
Hmm.
the machine. I wouldn't want that to clot.
True.
So it makes sense if that was the case to have your antidote on hand. That is something I don't know, Ryan.
Yeah, I don't know.
I would like to say yes,
Makes sense
simply
though.
because we're dealing with a lot of blood, but that is something I don't definitively know.
Yeah, they didn't. It wasn't dialysis wasn't a particularly heavy part of this.
Very nice.
Hmm. Yeah, it's like bolus dose with a continuous infusion, so heparin drip makes sense. Is it always heparinized? I like that. That's fun.
I think that's real. That's not real. That sounds right to me.
So let's add that information since that seems to be the case. Heparin drip says for blood loss. That do be making sense. I never really thought about it. I do like the word heparinized. Sounds cool.
Heparinized.
Do they have Coban? There's bleeding. Oh, okay. Sorry, I'm tired.
Yeah.
So peritoneal, this one is gonna be through the peritoneal. Dialysis basically through the peritoneal cavity. You're able to move around, do stuff, sit around with your little bag, more independent and stuff. Don't worry too much about like the faces of it. Worry more about the issues. So what issues do you think could arise from peritoneal dialysis? So yeah, peritonitis. Exactly. So peritonitis.
Heparinized.
So you're gonna assess for abdominal distension, the what's it called? The firm abdomen, nausea, vomiting. Probably have a nasty looking cloudy or frothy solution from dialysis. Treat with antibiotics. This one is hyperglycemia, yeah. So the reason for that, um, yeah, the diacylate concentration is sugar. Let me double check everything. Yeah, there's glucose concentrations in there. So the way it pulls is from glucose, the glucose inside the solutions, because it uses the glucose to pull.
It's so cool.
Which is cool, honestly. So definitely monitor blood glucose, give insulin if needed. We talked about that. Outflow, yeah. So what do you do if there's issues with the tubing or the flow? I know. Yeah, repositioning might be kinked. Reposition the patient. Can it be sure? Yeah, you can relieve patient pressure in the abdomen. And have them poop. All the stuff can help with the outflow. They might have abdominal pain, so again, reposition. That's like a little minor thing. Abdominal pain. Could be related to eye flow or position related, so reposition them. Considerations. I think this one is, what would I even put for this? Let's see. Again, I guess your normal dry versus wet weight. Vital signs before and after. Aseptic technique. And the biggest thing is probably monitor the blood glucose. Because that's kind of how it operates. That's about it. This probably could have been done in 2 sessions, but I wanted to knock it out today. Yeah, let me know if you guys have any questions on this. In terms of the test, I think Galen already mentioned it, that at least for renal, I can expect that to be relatively the same. In terms of cardiac, it's hard to say if there's been changes to the tests in that sense. I'm not really sure. Yeah, it's hard to say if she's using her own questions this time or not, or if the weird questions that everybody had issues with got fixed or not. Not really sure. It is a lot. Um, yeah. Any questions on anything we just talked about? Peritoneal dialysis. Focus a lot on the management, I would say. The management for the chronic and acute more than anything. Definitely you should know how to calculate the map. If not now, it'll come up multiple times later. Um, yeah, just keep in mind. Yeah, we did. So it's right here. So keep in mind your complications for your different dialysis, I guess. So hyperglycemia, hyperitonitis are like the biggest things here. With the peritoneal, kinking and repositioning, uh, hemodialysis, the disequilibrium syndrome. So how to manage that. Again, always think about the wet and dry weight. 1 kilogram is 1 liter. Hold the BP meds is huge for that one. But for the most part, it's not like too hyper detailed on the analysis, I don't call. Management and definitely your lab. You should understand how you should definitely understand how the renal impairment affects your labs and stuff. Management, like the medications you would take, how kidneys can lead to different electrolyte imbalances, fluid retention, um, What else? Anemia, like Epigen, you can use Epigen and stuff. That's pretty much it.